You know, there is this phrase that pretty much everyone uses at some point.
Right.
You wake up on the wrong side of the bed, or maybe you're just having a low energy week and you say, man, I'm so depressed today.
Right. Or you clean the whole house and jokes that you're being a bit bipolar.
Exactly. It's completely part of the vernacular now. We use these heavy clinical terms to describe what are, essentially normal human fluctuations.
But they're not the same thing. Not even close.
And that's why today we're drawing a hard line in the sand. We're looking at what happens when those fluctuations stop being just moods and start becoming, well, medical conditions.
Mm-hmm.
We are diving deep into a comprehensive medical and nursing presentation on affective disorders.
And this is, it's heavy stuff, but it's so important. Our mission today is to decode the clinical reality of things like major depressive disorder and bipolar disorder.
Right.
We want to understand not just the definitions, which are often misunderstood, but the biological machinery behind them. I mean, why does the brain do this?
And looking at the source material, the scale of this is, well, it's hard to ignore.
Oh, not at all. We aren't talking about rare conditions here. Depression is a leading cause of disability worldwide.
Worldwide?
In the U.S. alone, you're looking at about 7% of the population.
Mm-hmm.
That is millions of people. But what really jumps out from the data are the demographic splits.
The age gap really surprised me. I mean, you tend to think of health issues as things that get worse as you get older.
Right, bad knees, yeah.
Right, or high blood pressure. But the data says the prevalence for 18 to 29-year-olds is threefold higher than for people over 60.
It's startling. The incidence peaks in the 20s.
Mm.
This is hitting people right when they're trying to start their lives, build careers, form relationships.
And then there's a gender gap, too.
A big one. Females have threefold higher rates of depression than males.
So we aren't just talking about feeling sad. We're talking about a profound disruption to the brain's regulation of emotion that is hitting young adults and women disproportionately.
Precisely. And the source emphasizes that the trajectory is unpredictable. For some, it's chronic, a lifelong battle. For others, they might have years of no symptoms between episodes.
So it's not a single path.
Not at all.
Yeah.
But regardless of the pattern, it requires a clinical understanding because it affects everything. Sleep, appetite, movement, and thought.
Okay, so let's unpack this. We have a lot of ground to cover. We're going to get into major depressive disorder, break down the bipolar spectrum, which is way more nuanced than I realized. Look at this incredible, almost scary concept called the kindling theory. And finally, we have to talk about the reality of suicide prevention.
Let's start with the big one, major depressive disorder, or MDD.
Okay, so going back to what we said earlier, I'm sad my favorite sports team lost.
Yeah.
That is not MDD.
No. Sadness is an emotion. MDD is a clinical syndrome. The presentation makes a very clear distinction. To meet the criteria, you need more than just a low mood. There is a specific symptom highlighted here called anhedonia.
Anhedonia. That's a word that sounds exactly like what it is.
It is. It's the lack of interest or pleasure in things you used to love. And it's important to understand the depth of that.
It's not just being bored.
No. It's not that you go to the movies and you're sad while watching the movie. It's that the mechanism in your brain that processes enjoyment is offline. You literally cannot derive pleasure.
That sounds terrifying. It's not sadness, it's just emptiness.
A flatness, yes. And it's accompanied by physical signals. This isn't just all in your head.
Right.
We see significant weight loss or gain, insomnia, or the opposite, hypersomnia.
Okay.
But one of the most telling signs mentioned in the text is psychomotor retardation.
That phrase sounds incredibly clinical. Translate that for us. What does it look like in a person?
It means the person is moving or thinking so slowly that other people actually notice it. It's not just internal fatigue.
So it's visible.
Oh, yes. It's like their limbs are wading through molasses. Their speech might be slow, their reaction times lagged.
So the internal chemistry is actually breaking the external motor functions.
Exactly. Or, tragically, it can flip to agitation, where they physically cannot sit still. They're pacing, wringing their hands, unable to settle. It just shows how physical this disorder is.
Now, I want to get into the subtypes because I think this is where some really interesting insight comes in. We tend to lump all depression together, but the source breaks them down. There's one called melancholic depression that sounds particularly brutal.
Melancholic depression is considered a very severe form. The distinct feature here is the timing. It's usually worse in the morning.
Which seems cruel, right? Waking up should be the fresh start.
Instead, patients experience early morning awakening. They wake up way before they want to, 3 or 4 a.m., and they cannot get back to sleep.
And that anhedonia we talked about.
In melancholic depression, it's near total. There is essentially zero reaction to previously enjoyable activities. It's a complete blackout of joy.
Then you have the one that, honestly, I had to double take at the name atypical depression.
Yeah, it's ironically named.
Because when I read the symptoms, I thought, wait, isn't this what we usually see?
Well, atypical just means it doesn't follow that classic melancholic pattern we just described. The key difference is mood reactivity. In melancholic depression, nothing cheers you up. You could win the lottery, and you'd still feel flat. In atypical depression, a positive event can briefly lift the mood.
Oh, okay. So you can have a moment of okayness before sinking back down.
Exactly.
But physically, atypical seems to have its own unique signature. The source mentions leaden paralysis.
That is such a vivid description. Patients report a heavy feeling in their arms or legs, specifically like they are made of lead.
Wow.
And unlike the melancholic type who can't sleep, atypical patients tend to oversleep, hypersomnia, and they have a significant increase in appetite, often craving carbs.
So melancholic is insomnia and weight loss. Atypical is oversleeping and weight gain.
Correct. And recognizing these subtypes helps doctors choose the right medication.
We also need to touch on postpartum. The source makes a distinction here that I think every parent or partner of a parent needs to know. There's postpartum depression, and then there is postpartum psychosis.
This is vital. Postpartum depression is relatively common, impacting about 15% of women. It's linked to that massive drop in estrogen and progesterone after birth, plus, sleep deprivation. It looks like MDD.
But psychosis is a different beast.
Entirely. It's much rarer, 1 to 2 per 1,000 women. It involves delusions or hallucinations. And the statistic associated with this is chilling.
Yeah.
The source notes that postpartum psychosis is a leading cause of the murder of children under 1 year old.
That's heavy. It's hard to even process that.
It's a medical emergency.
Yeah.
The mother has a break from reality. It's not malice, it's delusion. She might believe the child is possessed or that she has to save them from a worse fate. It requires immediate hospitalization.
It really underscores that these are biological events, not character flaws.
Absolutely.
Which brings us to the other side of the affective coin. We've talked about the lows. Let's talk about the highs. Bipolar disorder.
This is probably the most misused term in pop culture. Weather is so bipolar.
Right. But clinically, the source divides it into Bipolar I and Bipolar II. And I'll be honest, I always thought Bipolar I was just the first one, or the mild one.
That's a common misconception. Actually, Bipolar I is the one with the higher ceiling. The main divider is the intensity of the mania. Bipolar I requires at least one full manic episode.
And let's define a manic episode. This isn't just having a great day and cleaning the garage.
No. For a diagnosis, the mania must last at least 7 days or be severe enough to land you in the hospital. We're talking about grandiosity.
Like believing you have superpowers.
Or special connections to God, or that you're a famous genius who can solve world peace in an afternoon. Plus, pressured speech, where you can't get the words out fast enough.
And a flight of ideas.
Right, where thoughts are racing faster than you can track. The source lists some risky behaviors too, like buying sprees, hypersexuality.
Yeah.
And a hallmark is a decreased need for sleep. This is crucial. They aren't insomniacs who want to sleep, but can't. They feel they don't need sleep. They might sleep 2 hours and feel fully charged.
So it causes severe impairment.
Severe impairment in social or work life, yes.
Okay, so if that's Bipolar I, what is Bipolar II?
Bipolar II involves a hypomanic episode. Think of hypo as under. It's a mania that doesn't quite hit that ceiling.
So it's milder.
The mania is milder, yes. It lasts about 4 days. It's an elevated mood, but, and this is key, it is not severe enough to cause major rejection or impairment in their job or social life.
So they still function.
Function and then some. People in hypomania can be incredibly productive, charismatic, and energetic.
So why is it a disorder? That sounds kind of great.
Because of the crash. Bipolar II requires a past major depressive episode to confirm the diagnosis. So they swing between this productive high-energy hypomania and deep, crushing depression. The instability is the disorder.
I see. So bipolar area is defined by the mania. You don't even technically need the depression for the diagnosis?
Though it usually happens, yes.
And bipolar II is defined by the swing between hypomania and depression.
You got it. And there's a third one mentioned briefly, cyclothymia.
Right.
Think of it as the slow burn version. It lasts for at least 2 years. The person cycles between mild depression and hypomanic symptoms, but they never quite hit the extreme criteria for full mania or major depression.
A roller coaster with smaller hills. But the ride never stops.
That's a good way to put it.
Speaking of the ride not stopping, this brings us to what I think is the most fascinating concept in this entire deep dive, the kindling theory. This completely changed how I look at stress.
It is a compelling neurochemical concept. The theory borrows from physics how you start a fire. You use small sticks, kindling, to get it going.
So how does that apply to the brain?
The idea is that cumulative stress and those low-level electrical impulses or chemical shifts we experience during hard times actually sensitize the neurons.
So the brain gets more and more reactive over time.
Exactly. Initially, you might need a major stressful event, a divorce, a death in the family, to trigger a mood episode. But as pathways get kindled or sensitized, the threshold drops.
So it takes less to set it off.
Way less. Eventually, the brain no longer needs a stimulus.
The neurons just start firing on their own.
Yes. The fire starts without a match.
That explains the cycling nature of the disorder, doesn't it? Why someone might have a manic or depressive episode out of nowhere when life is actually going fine.
Precisely. It suggests that untreated episodes essentially rewire the brain to be more prone to future episodes. It's why early treatment is so critical.
Wow.
You aren't just treating the current mood, you're trying to stop that kindling process before it becomes a self-sustaining fire.
He's slightly terrifying, but also empowering. It highlights the need for intervention. So what causes the spark initially? Let's talk etiology, nature versus nurture.
It's always a mix, but in affective disorders, the biological signal is incredibly strong, especially with genetics. If you have a first-degree relative with major depressive disorder, your risk doubles.
But for bipolar, the numbers are even starker, aren't they?
Much starker. Family history is the single highest risk factor for bipolar disorder. There's a tenfold increased risk. And the twin studies are fascinating.
Oh, yeah.
If you look at identical twins, they are 2 to 4 times more likely to share the diagnosis than fraternal twins.
That just screams genetic component. It's hardwired into the code.
It is. And inside the brain, that code translates to a chemical gain. We always hear about serotonin,
The happy chemical.
roughly speaking. In depression, we see deficits in serotonin and norepinephrine. But in mania, the script flips. Norepinephrine is significantly increased. It's like the throttle is stuck open.
There is also a note about the thyroid. I feel like the thyroid is the unsung hero or villain of mental health.
It's a classic medical detective rule-out. The source notes that 5 to 10% of depressed patients actually have thyroid dysfunction.
So you could be in therapy for depression, but really your thyroid is just sluggish.
Exactly. And curiously, half of rapid cycling bipolar patients have hypothyroidism. So before you start psychiatric meds, you always check the thyroid.
Because sometimes it's a hormonal issue, not a psychiatric one.
That's right.
Okay, now before we get to the meds, there were some psychological theories mentioned. Learn helplessness.
This is a famous theory. It suggests that clinical depression results from a real or perceived lack of control.
Okay.
If you feel that no matter what you do, you cannot change a bad situation, like a bad job or an abusive relationship, you eventually stop trying.
You learn that you are helpless.
And that learning manifests as depression. Even if an exit door opens, you might not take it because you've been conditioned to believe it won't matter.
So how do we fix it? We've got the chemistry, we've got the psychology. What is the gold standard for treatment?
The consensus is clear. Psychotherapy plus medication. It's better than either one alone. You need to address the chemistry and the cognition.
Let's look at the medicine cabinet. We know the SSRIs and SNRIs for depression. But for bipolar, the star of the show seems to be lithium.
Lithium is fascinating. It's not a complex synthesized molecule from a lab. It's a natural salt.
A salt? That's wild.
It's number 3 on the periodic table. It's actually found in trace amounts in the human body. And despite all the new fancy drugs developed over decades, lithium remains a powerhouse.
Really?
It has a 70 to 80% response rate for mania. It essentially puts a cap on that norepinephrine throttle we talked about. It stabilizes the electricity.
But looking at the list of treatments in the source, there were some entries that really surprised me. Things that used to be considered street drugs are now on the medical chart.
It shows how the field is evolving. The source explicitly lists esketamine.
Which is related to ketamine, the party drug.
It's derived from it, yes.
Yeah.
It works on a completely different pathway than serotonin. It can offer rapid relief for people who haven't responded to traditional meds.
And then there was psilocybin.
Yep, the source explicitly calls out magic mushrooms.
We are seeing a renaissance in psychedelic medicine.
We are. The research suggests that these substances, under clinical supervision, might help reset those kindled pathways we talked about.
And for the most treatment-resistant cases,
We still have ECT, electroconvulsive therapy, and TMS, transcranial magnetic stimulation.
these aren't the one flew over the cuckoo's nest treatments anymore, are they?
No, not at all. They are highly refined. They use electricity or magnetic fields to stimulate specific brain regions. When medication just isn't breaking through and the patient is suffering deeply, these can be life-saving.
We have to shift gears now. We can't talk about these disorders without talking about the most critical risk associated with them. The source ends with a very serious section on suicide.
This is the somber reality. We can get caught up in the fascinating neuroscience, but the endpoint of untreated affective disorders can be fatal. Suicide was the 11th leading cause of death in the U.S. in 2023.
The stats are heartbreaking. One person dies every 11 minutes. And there's a gender paradox here too, isn't there? You mentioned earlier that women are 3 times more likely to be depressed.
Yes, but suicide deaths are 4 times higher in males.
Why the discrepancy?
It comes down to the means. Females statistically attempt suicide more often, but they tend to use methods like overdosing, which allows for a window of rescue. Males more frequently use lethal means firearms, specifically resulting in much higher immediate mortality.
That is an important distinction for families to know. Now, to help clinicians spot the risk, the source details an acronym: SAD persons.
It's a risk assessment tool. It helps you tally up the risk factors. So S is for sex, specifically male for the reasons we just discussed. A for age risk is highest under 19 or over 45. D for depression.
P is previous attempt.
Correct, and that is a huge predictor. E is ethanol abuse. Alcohol plays a huge role in lowering inhibition. R is rational thinking loss. S is social support lacking.
O for organized plan. That organized plan part is key, right?
Crucial. There's a difference between vague thoughts of not wanting to be here and having a specific plan, time, and means. That is a code red.
Okay.
N is for the challenge. No spouse being single or widowed increases risk. And the last S is for sickness. Chronic illness wears people down.
It's a grim checklist, but it saves lives.
Mm.
What can we actually do, though, if someone is listening and they are worried about someone or themselves?
The first and most immediate resource mentioned is the 988 Suicide and Crisis Lifeline. It's a vital number to know.
988.
In a clinical setting, interventions involve immediate safety, removing harmful items like shoelaces, belts, razors, and often implementing one-to-one supervision. You don't leave them alone.
And I think we need to bust a major myth here. I've heard people say, don't ask them if they're suicidal, you'll put the idea in their head.
That is a dangerous,
Right.
persistent myth. The source is very clear. Asking about suicide screening for it does not plant the idea. If the idea is there, it's already there.
So asking is actually a relief.
Often, yes. It opens a door. It validates their pain. You have to ask the question to get the answer that allows you to help. You cannot treat what you don't know about.
That is so important. We have to be brave enough to ask.
Absolutely. The goal is to get them to a place where they can contract for safety, agreeing to talk to someone before acting and engage in treatment.
You know, we've covered a lot today. From the heavy physical sensation of leaden paralysis to the dangerous energy of mania and the tragedy of suicide, it really drives home how complex our brain chemistry is.
It does. It shows that our reality, how we feel, how we perceive the world, whether we can get out of bed, is tied to these neurotransmitters and genetic markers. It's fragile.
But it's also treatable. That's the hope in the data.
Exactly. We have lithium, we have therapy, we have new treatments coming online. It's not a life sentence.
I keep thinking back to that kindling theory.
Me too. It sticks with you.
It changes how I view stress management. It's not just about relaxing because it feels nice. If stress leaves a permanent sensitization on our neural pathways, then protecting our mental health is literally about preventing the physical rewiring of our brains.
That is a profound way to look at it. We aren't just managing moods. We are maintaining the structural integrity of our neural networks. We are keeping the fire from starting.
A lot to think about. Thank you for walking us through this.
My pleasure.
And to our listener, take care of your brain. We'll catch you on the next deep dive.